sleeves and bypasses, probably some band removal or maintenance, but those will probably be an outpatient procedure. They shouldn't ever really need to be admitted to the hospital for any reason, hopefully. Duodenal switches that you saw in there are going to be pretty rare, if ever. I hope that he doesn't do them, because those patients are just really hard to manage after the fact, and I don't want us in the clinic to have to deal with them. But it's a pretty invasive procedure. So I know he has done them in the past, but I don't think it's something that we'll see very often. Dr. Ahuja does about 50-50 as far as sleeves and bypasses, I would say. We definitely do more sleeves than bypasses here, but that's starting to shift a little bit. The sleeve is the most popular bariatric surgery in the United States, but the bypass has been around the longest. It's kind of like the go-to when you hear about bariatric surgery. Something that we see a lot of now is that because we have done so many sleeves here the last few years, that a lot of those people are coming back with really bad reflux. So we're revising a lot of those sleeves and turning them into bypasses, because the reflux is getting so bad. We want to prevent Barrett's esophagus and stuff like that. So that being said, I would say with Dr. Ahuja we can expect about 50-50, both types of procedures. I'm just not sure yet how that pendulum is going to go. A little bit just about bariatric surgery patients in general. Most of our patients are super motivated and really excited to be having this surgery. So for the most part, they're going to kind of help you almost remember what's supposed to be happening, because they come to an all-day long education day with us right before surgery, and we kind of walk them through what to expect in the hospital. So they come in with a lot of knowledge. Most patients have been with us in the clinic for at least 3 months on average before they ever even get scheduled for surgery. So we've done a lot of education with them. Hopefully they've kind of got it all together for the most part. You always have the ones every now and then that just aren't really getting it. You know, you're going to have that no matter what. But if they've kind of checked the boxes and done what we've asked, we can't really say, no, we can't do surgery on you. So we get those sometimes. Most of these patients have been trying to lose weight and diet for most of their young adult and adult life. So they feel pretty defeated and pretty bad about themselves. They don't have a lot of self-esteem. So it's really important when we care for them that we are motivating and encouraging and positive in everything. Because it doesn't take much, especially before surgery, for a patient to have like one bad clinic visit or one thing not go well, and they just kind of throw it all away and give up, because that's kind of their MO. That's what they've done. So stay positive, encouraging. Try not to like comment on their size or their weight. I mean, they know what they're here for. You know, they're not dumb, but we still want to be sensitive to that. So trying not to say like, oh, we need the big walker or the extra wide wheelchair. You know, just try to say we need the bariatric wheelchair or something like that, instead of using like a slang term around those pieces of equipment. For your all safety, there will be hover mats underneath all of the patients. Should you need to transfer them to another bed or something, they'll come to you on a hover mat. We will have, if we need it, extra equipment. I'm actually going to try to go this week and make sure I check out weight capacities of the walkers and wheelchairs and whatnot on that unit. In ICU, most of the commodes and walkers and wheelchairs and stuff here are already 600 plus capacity, and we're not going to do surgery on anybody that weighs usually over 500 pounds. So we should be good there. It's important as you're like transferring the patients, kind of let them help themselves. They know kind of how to modify for their body size and how they need to get up and get themselves positioned to stand up or whatever. It may not look pretty, but they've been doing it for a long time, so a lot of times it's easier if you kind of let them tell you how to help them instead of you trying to push or pull on them or whatever. That's just kind of the overview of everything. So you all have this nursing checklist, and this kind of walks you through their care on the floor. And Dr. Ahuja has looked at this, so this is per his specifications. This will all be reflected in order sets. Whitney especially can tell you that these patients are really pretty easy because it's all black and white in front of you. Every bariatric patient is treated almost exactly the same. So every time you know you have a bariatric patient, you know exactly what you're going to get that day. There's a lot in those order sets, but they're so specific and so spelled out that it's really pretty easy to follow, especially if you have this kind of side by side to help you stay on track. And we'll make sure that this checklist is available for you all when you need it. I'm making a binder of resources that will stay at the nurse's station that's kind of beside the rooms where the bariatric patients will be, so that way you always have everything at your fingertips. So patients will come up to 3100 straight from PACU. They're like an early morning admit to the hospital. They don't stay overnight the night before or anything like that. And the first really hour when they're on your unit is going to be the busiest, right after surgery. From there, things kind of calm down. They're going to have IV fluids to keep going. They're going to have IV Tylenol that has to be run right away. Lots of stuff. It's all on the checklist, so I don't want to leave anything out. We'll kind of go through that. But after that hour kind of passes, things settle down. So like last week when we were with the other group and we were watching the patient, you know, this nurse was getting 3 bariatric patients that day. But she got the first one up and going first hour or so. That was done. The second one came up, got them going the hour or so, and then by that point it was time to go check on the first patient again. And then the third one came up, she got them going, and then from there it's just kind of following up with their care. So once you get the routine down, it's pretty easy. And Whitney can kind of speak more to that in a minute than I can, because she's actually done it. So let's just kind of walk through this checklist and see. So they're going to have lactated ringers running at 75 mils an hour. They will all be on a PCA that was started in the PACU. Typically dilaudid is what Dr. Ahuja will use. And then they will all have telemonitoring at least through that first night after surgery. Vitals checked every 15 minutes for the first hour, then 30 minutes for the next hour, and then every 4 hours. They want them to be moving their feet around to help with circulation. While they are on the PCA, of course, they're going to have their end-tidal CO2 monitoring going on. They will have O2 on as well. And then there's instructions in the order set on how to titrate that, when to titrate that. So we get a baseline CO2 on them before surgery. So that will be available for you to see and kind of refer to, so you know how they're tracking after surgery, if they're staying kind of within that normal for them or not. Head of bed at 30 degrees all the time. SCDs will be on them at all times when they're in bed or not really moving around. The top rails of the bed, they want those up whenever the patient's in bed, of course. And then the IV Tylenol is given to the patient 4 hours after their intra-op dose. So Dr. Ahuja actually has patients take Tylenol on their way to the hospital, and then they give it to them during the surgery, and then 4 hours after that intra-op dose, they need the next dose. So there's a lot of times that once they get up to you guys, there may only be 40 minutes, an hour until they're needing that dose of Tylenol. The good news is it runs really fast. So Tylenol is something that you have to call the pharmacy for. So just keep that in the back of your mind. Once the patient gets there, you'll want to call them, make sure you have that when you need it. What was it, like 20 minutes they only had to get her that Tylenol last week? It was a pretty short period of time. Yeah. Usually it doesn't happen. Usually there's about an hour. So the patient will get a total of 3 doses of IV Tylenol across the course of the period of time in the hospital. And then they have scheduled meds, Protonix, Zofran, Reglan, and Thiamine. They also have PRN nausea meds, Zofran, Phenergan, and then metoprolol for blood pressure is PRN as well. Here, that's a scheduled med, but Dr. Ahuja just does it as needed.
So he had one the other day. It was a colectomy, but he kind of ordered his bariatric orders.
Oh, did he?
Yeah, it was like but the blood pressure was ordered every 6 hours. It was like blood pressure less than 90, do not give. So it's like if it's 92.
We were all just to give it.
Yeah, I don't blame you.
Oh yeah,
I don't blame you.
Didn't I?
Yeah.
Yeah. Interesting. Well, I mean, as always, he's going to be available,
Yeah.
so if you ever are concerned.
Yeah, so we called him.
Okay.
What's your judgment?
He had me on the last dose though.
Yeah.
Like before he went home, because I said, can you please sit down and teach me why we're doing this? Because it's going against everything, like
Right.
every nurse on the floor is panicked because you're telling us to go against what we've learned. And he just laughed and he said, well, no, and she said, okay, but I expected her to be really hypertensive and she wasn't. And I said, no, she wasn't, but you still had this committee.
Right.
I wasn't sure if she just had like a history of heart rate issues or what.
Sure. He's a really good teacher, and he is not afraid to like sit down and talk to you through a process. You know, anytime, he's still pretty new to us. He's only been here since the end of August. So, but anytime I have questions or anything, I just sit down and like, hey, explain this to me, and he will actually take the time, which is awesome.
Yeah, he seems very personable.
Yeah, he is. I think he's going to be really great to work with. They will draw labs in the PACU. Typically, they're not back yet by the time they're leaving PACU. So that's something that you all will kind of have to review and then replace electrolytes as needed. So that is one step that you'll have to keep in mind. What was it, Whitney, you said it, magnesium almost always? Is that what you said you have to replace? Okay. Insulin, patients will be taken off of all of their normally occurring diabetes meds before surgery, and we switch them over to correction scale only, and then we continue that in the hospital. If somebody is uncontrolled, they'll probably continue kind of a basal long-acting insulin on top of that correction scale, but most patients only have that correction scale ordered. You'll probably see a glycemic protocol you will see for anybody with diabetes, and then anyone who has kind of that borderline A1C, they'll probably order it too. There's the stress of surgery may be enough to kind of send them up a little higher. Sleeve patients can have ice chips. Bypass patients don't get anything. So this first patient is technically a bypass, so she won't be able to have anything other than like sponges to keep her mouth wet and stuff that whole first day and then night after surgery. Dr. Ahuja is pretty adamant about a good I&O count, so we'll want to do that for the patients. They do not get catheters for this procedure, which is awesome for them. So we have them try to go to the bathroom right before the procedure, and then afterwards, once they're up on the floor, if they say, hey, I gotta go, you help them up and let them go. So they'll be able to do that. Just make sure that that's all tracked. Egress test. Have either of you ever heard of that before? Okay. Whitney's gonna come demonstrate.
I'm gonna get a gate belt.
She's ready.
I'm almost ready. I gotta go get a gate belt.
None of us had heard of it either, so don't worry. It's just kind of to make sure that the patients have their bearings and aren't too loopy still from coming up out of surgery, because we want them ideally up and even if it's just a few steps to the door and back, within 4 hours after the surgery is over. So, sometimes people are still a little sleepy.
Stacey, are you gonna be my volunteer again?
Miss Chelsea will have to be, I'm gonna
Sure.
record it.
Look, I'm in a chair already.
Okay. So the egress test is super easy. You're just gonna need, look at Stacey.
I'm on it, I'm on it.
She is.
You just need a gate belt to do it. So obviously, the first thing I didn't hear you mention is that these patients, you have to just let them get up on their own. Like I know as nurses, we wanna, let me help you. And they're gonna have to, they've adapted. So let them get up on their own, don't pull on them, and just let them sit up. Your beds are not near as high as they are here, so you guys won't have near as problem as they do here. But let them sit on the side of the bed, and that's where you start your test. So you put your gate belts on. You may have to go up a little higher with their port sights, and you'll see that when we go watch that patient later, but. Is that too hard?
No, you're good.
Okay. So I hate to do this in a moving chair, so don't fall, okay?
I won't.
I don't have a chair that doesn't have wheels.
That's okay.
Don't do this on a moving chair with your patient if they're sitting up. Make sure that it's locked, but there's 3 parts to it. So the first part is you're gonna have them stand up and sit down. They're probably gonna have a walker in front of them. I didn't bring one for her today, but I will try to hold the chair so that you don't move. But
Okay, so-
she's gonna stand up and sit down. It doesn't have to be quickly, it's really at her own pace. So 3 times she's gonna do it. So if they take a little bit of time, that's fine. And then on the 3rd time, I always just tell them to stay standing if they want to at that point. You're looking for, are they dizzy? Are they falling back down? Are they having any issues standing up? Do they feel kind of wobbly? Because you're getting ready to walk them, you don't want to walk them in the hallway and have them fall. So that's really the whole point of this. So the next step, and you should be holding on to this, but just for demonstrations, I'm not. She's going to take a step forward with her right foot, bear weight on it, and come back. And then she's gonna do the same thing with her left foot and come back, and she's gonna do that 3 times. You don't want them to take a full step forward. Some patients really wanna go, but if they start to fall, you want them to be able to just come back onto the bed here. So when she does that 3 times, again, you're holding on to her. So now she's going to take a full step forward, bear weight, and then a full step backwards. And she'll do that 3 times.
3 times on each side, or just 3 times?
3 full steps.
Okay.
And then usually if they're doing okay at that point, on that 3rd step, you can just start to go. But the whole time you're asking them, do they feel dizzy, do they feel wobbly? You're looking for that, are they unable to stand? Ideally, if you do this and they feel okay, they'll do okay in the hallway. But if they're not, then you would not proceed with walking. You would stop at any point during the test that they did not feel okay, and you would have them lay back down or sit back down. And usually you're gonna call, so you would call Dr. Ahuja. If you're working, you work nights, right? What do you work? Days. So on day shift, you probably will have some time to come back in later and try it. Night shift, they may have you wait, or they probably have already walked at that point. You only do this on the first time that you have to get them up unless they failed. Sometimes they have you, if they fail and they can't do it, they have PT come and evaluate them. So it's really just gonna be his preference at that point. Sometimes if you get them up too early, like maybe they have to go to the bathroom right away and they're still a little out of it from surgery, you can wait an hour and come back and they're fine. So it's just kind of dependent. We used to wait until right at that 4-hour time to get them up, but now with no Foley, sometimes they have to get up right away. So some patients do better and some patients don't, but I've never had somebody fail twice.
So is there like a documentation that you have to chart this out?
There is. It's on your daily care, and when you're putting where you can ambulate, it's one of the like where you can put walker and all of that. Egress test is one of the
Okay.
options on there, and it just gives you a pass or a fail.
Okay.
So you just have to do it that first time. So you may never have to document it because they're usually up and going by that point, but you would definitely have to document that.
Yes.
Chelsea, didn't you say that they're already kind of taught how to do this?
Yeah, they are. We show them, or at least tell them, hey, their nurses are gonna have you kind of take some steps by the bed, make sure that you're stable before we just send you out down the hallway, so.
We also have somebody follow with a walker or a wheelchair.
Mhm.
I am a big believer that the families there make them push a wheelchair. They usually are pretty good at that. I know that you always don't have someone at your disposal. So usually spouses parents, whoever's there, they will push that wheelchair, and then when you're out walking around, if they need to sit down, you have something. Because you're gonna, that first time especially, you'll have poles and oxygen and all sorts of things. You won't have enough hands to pull that behind. By the time they get to you, and as you get, the longer they go, the more stuff they lose, like everything starts to come off. So by the next day, they're out walking around on their own, usually.
Yeah.
So.
If you've got a couple of patients there, they're like, oh hey, like waving to each other in the hallway, how long did you go for today? You know, it's funny. It's really fun. So, all right, questions? Okay. Take off my face belt. So they will have an order for incentive spirometer every hour while they're awake in the hospital. I think it goes to respiratory, but I mean the respiratory therapist is not going to come in every single hour, you know, so just make sure you're reminding the patient to do that. They have been instructed on how to do their incentive spirometer. We have them doing it at home a couple of weeks before surgery, so they should know what to do as far as that goes. Dr. Ahuja is very much like this is a nurse-driven patient. So if you ever have a question, you ever see that something that was supposed to be done wasn't done, he really relies on you all on the floor to call whoever it is that needs to be doing what they're supposed to do, or call him and kind of keep the flow going for these guys. Reconcile home meds with the surgeon if it's not already done. Watch for complications like bleeding, a PE, a leak, or some type of obstruction. We'll actually have a sheet for you all in the binder, and we can even have multiple copies if each of you wants one to keep with your stuff, that has signs and symptoms of complications of bariatric surgery and kind of what to do about it. So we have that already. We'll make sure you guys have that before the first surgery. When you call the surgeon, make sure that obviously you have some information prepared to tell them so they can get an idea of what's going on. And something else I forgot to mention too, these patients will have 2 IV lines. So he originally had said that only 1 for sleeve patients, but then there was some concern because they get lactated ringers that isn't very compatible with a lot of other things that they're getting. So to prevent having to stop and start and stop and start and all of that, he said he's fine with having 2.
Will there be parameters for the hydralazine PRN for systolic
Yes.
blood pressure over something?
Yep, that will all be in the comments of the order sets, so. There's something else I was gonna say too. I will email Angie as well to make sure that there are enough channels on the IV poles. Ideally, it looked like last week 4 is what's needed really for these people, just because there's so much going on all at once, especially at the beginning, so. And then overnight, that first night after surgery, the same process just kind of continues. We'd like them to ambulate one more time before they go to bed, 8 or 9 o'clock if they're still awake. And then their IV fluids will continue. Night shift will probably be the ones checking the labs if they're back and replacing those electrolytes again if they're needed. Now this next one will actually be a little bit different. This says PCP will manage those other conditions. Dr. Ahuja admits to himself only, so he will manage all of those. I actually need to change that. Here, because the hospitalist program was kind of new, we always admitted everybody under the hospitalist as well as the surgeon, just to kind of use them. But Dr. Ahuja won't do that. It'll just be him. Vital signs every 4 hours. Keep them moving their feet and ankles. O2 titration if it needs to be. The end tidal will come off when the PCA is stopped, which happens in the morning, as well as the telemetry, and that isn't on here yet. It's something we have to add. So based on what time that order is for, it could be either one of you doing that, but typically first thing in the morning, if the patient's been stable, based on his parameters, which will be listed in there. You can discontinue the tele, so then that way, when they do their testing and stuff in the morning, they can leave the floor without you guys. SCDs, of course, all the scheduled meds, PRN meds for nausea, and they will also have a scopolamine patch on. It's not on in here because they already have it on before they come to you. We actually have them put that on the night before their surgery. So, electrolytes, we already talked about that. The insulin orders will still be there. Continue the ice chips for the sleeves, nothing at all throughout the night for bypasses. Urine output, the complications, and that's about it. So just kind of continuing on with the same protocol that was established. And then on post-op day 1, first thing the patients do, well, first of all, hopefully we're discontinuing the tele, and then they're going down to their upper GI. Dr. Ahuja probably won't do upper GIs on all of his patients for very long, but getting started he will. New place, new staff, he just kind of wants them to be familiar with what these surgeries look like. But they say once you've done about 100 surgeries and you've never had a patient with a leak, that you don't have to do those upper GIs anymore. Dr. Ahuja has done like 4,000 of them. So, but new place, so he'll probably go for a while. All right, radiology knows that these patients are having surgery. They are gonna have some time kind of blocked off first thing. They're gonna be expecting these bariatric patients on OR days have switched now to Mondays and Tuesdays. So he will be operating on Mondays and Tuesdays. New revelation this last week. So once the upper GI is okay, we'll get the preliminary report from the radiologist so these people can start drinking as soon as possible. So as soon as the upper GI comes back okay, then they can start their liquid diet. So they will be ordered a phase 1 diet, or you all will put in the order for phase 1, and discontinue that NPO order that's in there. And this is something else we'll have to change. Instead of the dietitian coming up to educate the patient and then starting phase 1, Dr. Ahuja, as soon as that diet order gets put in, he wants them to go ahead and get their liquids. So that way they can drink as soon as possible, and then the dietitian will just educate them before they go home. I don't love it, but that's what he wants to do, so that's okay. We'll go with it. What we'll probably have to do, and I'm still kind of finalizing these details with the food and nutrition department, is the nurse will probably have to call them to place the order for the patient, because the patient doesn't really know what's available. All they get is liquids and stuff, but they're going to want to pick their flavor of protein shake at least. So it'll probably require a phone call down to the kitchen to get those liquids for that patient, because it'll probably be after normal tray line service. But I will make sure we have the answer before that first patient. When you order phase 1, it automatically sends a consult to the dietitian, so they will know to come up and educate that patient. That happens with any bariatric diet that's ordered. We do want you all, though, as the patient is drinking, to kind of reinforce slow, steady sips, taking your time. They're going to get little 1-ounce cups, which is like the size of a medicine cup. And it should take them about 30 minutes to drink that entire little cup of fluid. We don't want them to like chug it back like a shot. So slow, steady sips, about 1 ounce every 30 minutes throughout that first day. If you have someone that's staying over to day 2, then it doubles, and then from there they can increase on their own. So we want the patients to always start drinking water first, because that's going to be the easiest, and then broth, protein shake, popsicles, Jell-O, those types of things. We really kind of save the Jell-O and the popsicles for last. Like if they've done water, fine, protein shake, broth, then offer them the Jell-O for the popsicle. Sometimes that texture just kind of settles weird with him at first. If they do want the Jell-O or the popsicle, just scoop some out or like break off a piece of the popsicle, put it in one of those little cups. That way they only get about an ounce of liquid at a time. As they increase their oral fluids, their IV fluids are going to decrease. And then the scheduled meds for Zofran and Reglan will stop and they'll just stay PRN. Protonics and insulin correction scale is ordered. Can stop the PCA in the morning. I believe is it 7 or 9 a.m.? I don't remember in the order set, but it's pretty early that they stop that. Do you remember, Whitney?
I feel like it's 9, but we always stopped it when the patient went downstairs.
So before they went to their
Yeah, like you
GI?
just unhooked it and then
Okay.
we would only hook the fluids back up when they came back up.
Okay, that's kind of what I thought, but just wanted to make sure. They may start some PO meds. What we tell them is to take anything like the size of an M&M or aspirin or smaller is fine. Anything else they would have to crush or like pop open the capsule and dump the powder out and take it in their protein shake or Jell-O or something like that. Wean or stop the O2. If you're not able to wean it, make sure you call the surgeon so we can make arrangements for home O2 if it's needed. Of course, vital signs. Heparin needs to be actually taken out and replaced with Lovenox. Dr. Afuja only does heparin for people that have a BMI above 50. Otherwise, he just does Lovenox that morning, early ambulation, and the SCDs for VTE prophylaxis. On that post-op day 1, we want the patient to stay up and mobile and moving around the unit as much as they want to or as much as they can. At a minimum, at least 3 times a day. They're out of bed, for sure. Incident spirometer, the PRN meds. The tele, like I said, will be discontinued that morning also before their upper GI. So I'll make sure that gets rearranged. And then if there's any case management needs, of course, ask Dr. Boucher, put in that consult however you're supposed to for any transportation, home O2, very rarely, but we have done home health a couple times for people, that kind of thing. All right, so the process for these patients, most of the time they're going home, well, sleeve patients are going home on post-op day 1. Bypass patients, at least to start, will stay 2 nights. They won't go home till the 2nd day. So if they have surgery on Monday, they'll go home Wednesday. That will probably change pretty quickly too. In Heron, Dr. Ahuja just kept all of his patients overnight. But again, new hospital, new staff, we're kind of lengthening it for those more complex patients just to give us more time to get them recovered at home. So
Are they already taught about their Lovenox, how to administer at home?
it's a good question. I don't know. We don't do that now because we don't really send them home with it unless they need it. The only times we'll bridge people to Lovenox pre-op if we need to, based on what they already take. And we do all of that on pre-op day, so I am assuming or hoping our nurses in the clinic teach the patients that, but I actually don't know. So I'll ask, and I'll find out. That stuff's nasty, those bruises it can leave sometimes. Okay, I'll ask and find out. And then for discharge, we try to make it pretty simple. So the patients already have all of their post-op appointments for the next year of their life scheduled with our clinic, so you don't have to worry about doing that. If they need more follow-up about giving themselves insulin at home, feel free to reinforce that or call the diabetes educator. Patty is over there at Good Sam. all the patients who are getting sliding scale insulin to use preoperatively have seen the diabetes educator before surgery already. But if on the off chance it was that like borderline patient who we didn't send for diabetes education before surgery and now is going home with insulin, they may not really know what they're doing. So feel free to call Patty if needed. Of course, review the discharge instructions. If there's any doubts about anything, don't hesitate to reach out to, Dr. Ahuja or the dietitian or whoever. Katie, I believe, is the dietitian for that unit. I've never met her personally. She's newer, so I'm not sure, but they've already gotten education about everything too. As far as prescriptions goes, they have all of their post-op med prescriptions before surgery also. So unless something got changed while they were in the hospital, they should already have everything that they need at home waiting for them. Patients that do have a gallbladder will start Actigol about 7 days after surgery, but we're seeing them in the clinic at that point, so that really shouldn't be anything that you need to talk to them about. We do ask that for people who are driving more than an hour home, that they get out of the car at that 1 hour mark and walk around a little bit, just to help with circulation and stuff. And we tell them that too before surgery, but just a reminder is good. Make sure that they've got contact info for our office, for the hospital, and their surgeon. I think Dr. Ahuja plans to give his cell phone number to patients, so that's great. I know our surgeons here do that. Works out well most of the time. Every now and then we have a patient who just like texts them about every little thing, and we have to be like, okay, stop. Work notes and things we've already taken care of with all their time off paperwork in the office, but should they for whatever reason require a note from the hospital, that's fine. They will stay on that phase 1 diet for 2 weeks after surgery, and they don't do anything different until they come back and see the dietitian again in the office. Some patients try to be like, so when can I eat this, or can I have this when I go home? And I always say, just if it's not on the list, you can't have it, at least not now. So wound care should be super simple. They're all gonna have like Dermabond closing their wounds. There may be an internal stitch or two, but that's about it. So wound care is super easy for them. Very, very rarely will somebody have a drain. Very rarely. We used to put drains in all of our bypass patients. We don't do that anymore. I think we've had, in the last year-ish since we stopped doing that, I've maybe had 2 patients that have gone home with a drain. So we really try to avoid it. We want them to stay moving around a little bit at home. We don't want them to go home and be a couch potato. And their lifting capacity is actually a little bit different than is in here. I need to change it as well. Dr. Ahuja says lifting no more than 25 pounds for a week and then as tolerated. Whereas Dr. Sudhakaran prefers them not to lift anything more than 10 pounds. So hopefully we'll have a come to Jesus on that and it'll be the same for everybody because it gets a little confusing. Our patients do get Exparel during surgery. It's kind of a nerve block type situation, so they can't have any other types of local medications like that for about 96 hours. So they'll come up from the OR with a wristband on. That'll have the date and time that Exparel is wearing off, and they need to just leave that wristband on until then. So they will have a list of the symptoms to look out for when to call the office or the surgeon if they're having issues. And then there are more, I guess, general instructions that you guys can print out based on what their diagnosis is. Don't print those for these patients because then they get confused because every surgeon is a little bit different, every procedure is a little bit different, sometimes the details are slightly off and we don't want them to get confused. So we just refer them back to all of our education materials that we've given them. So questions about the process? No? Okay. I gave you guys both the teal cover packet is the nutrition guide. I think it's page 6 in there that talks about the phase 1 diet. I wanna go over that with you a little bit, just so you kind of know what they're supposed to have. It's page 6. I think. Yes. So phase 1, well, first of all, this teal packet is what all the patients get, so you have what they're seeing at home, so that might be helpful in case they ever have a question. We refer them back to this for all of their nutrition information. We're in the process of kind of reorganizing this packet, but the content will essentially be the same. So phase 1 is sugar-free clear liquids and protein shakes. That's all they can have for the first couple of weeks. Chicken broth, beef broth, veggie broth, sugar-free Jell-O or sugar-free popsicles. Their protein shake of choice, as long as it's low in sugar. Water, that's about it. Decaf tea and coffee. Up to 64 ounces a day total is their goal. We know that they are not going to get there probably even by the end of the first week, because they're kind of learning how to drink all over again. So we just want them to do the best that they can. They'll go home with a kind of a fluid tracking chart to help them progress their fluid intake slowly. We don't want them to push it. If they feel pressure or pain or anything kind of right through here, that means they're drinking too fast or too much. So they need to back off a little bit. The big no-nos for them when it comes to fluids is no carbonation at all ever again, and very small amounts of caffeine, especially these first couple weeks, because they're going to be struggling to drink enough as it is. We don't want them getting dehydrated too.
So basically, don't take these guys a cup of water.
You can.
Or just like, because like a full cup, you know, it's hard to measure.
Right, so they're actually going to get a box with all their fluids in it. And in that box is going to have 1 ounce cups, a couple of just small drinking cups, and then a cup full of water. And that water is actually smart water, which is bottled water. It just has electrolytes in it. Usually no evidence to say that that's helpful, but Dr. Sudhakaran did it and Dr. Ahuja did it, so we just go with it. Whatever.
So that's while they're in the hospital, they'll
yes.
get this box up?
Yes, they'll get this box. So when you call to get their phase 1, it's gonna come up in like a cardboard box, a little white box. So everything that they drink should just be poured into those smaller cups, and they should really only get one of those cups about every 30 minutes. So we used to have the nurse bring every cup into the room every 30 minutes. Well, that's insane. And the patients have to do it themselves when they go home anyway. So we kind of have them do the first 3 or 4 drinks, let the nurse bring it in and kind of watch them throughout that first hour or so, and then kind of let the patient handle it from there. So yeah, small sips often. The first day we really tell them kind of just like get your mouth wet and swallow it and do it that way. This lasts for 2 weeks. The healing process as a whole for them takes about 3 months, so that's why if you're kind of reviewing that booklet, it takes 3 months for them to get back up to normal textured foods. Eventually, the tissue will kind of grow around the staples that are in there, holding their stomach together, and the staples don't really do anything anymore. So until then, we want to take it easy on their bellies, for sure. What else for phase 1? You guys might want to jot this down. So they can't get just any type of protein shake. Here in the hospital, they can only have Ensure High Protein. Either flavor is fine. OptiSource, which I believe is strawberry flavored. It comes in like a caramel, but it's super gross. supplement that you've probably never seen before called Clearly Protein. It's like a protein water. It's like a fruit punch flavor. And then Prostat, that stuff like you put in a tube feeding or something, technically meets our guidelines. I wouldn't encourage that necessarily, it's gross, but if somebody really wanted it, they could have it. So those are the only ones that are safe for the bariatric patients. I'm also finishing, it's actually off to marketing right now, so we make it look pretty before we print them. Kind of a cheat sheet for bariatric safe snacks and supplements, and then we'll laminate that, keep them on all the floors, so you have that to refer to also. Because sometimes, especially if they're a readmission, we'll be like, oh yeah, I can have that, I want some chips or whatever, and you're like, yeah, no, not for you. They try to get sneaky sometimes. So that's phase 1. They'll do that for 2 weeks. The second 2 weeks, just so you guys kind of know how it works, they will be on kind of a semi-solid diet. I don't like to say pureed because then they all think it comes out of a blender and it doesn't have to. Cottage cheese, light or very low sugar yogurt, scrambled eggs, tuna, canned chicken, any type of like baked white flaky fish is fine, sugar-free pudding, stuff like that. They do that for 2 weeks, and then after that, the next 2 months, they do basically a mechanical soft diet, ground meats, deli meat, cooked veggies, soft fresh fruits, things like that. And then 3 months later, they're back up to normal. The only, like I said, big time no-nos are carbonation and then coconut for bypass patients only. Coconut's really hard to digest, and their opening from their new stomach pouch into their intestine is only about the size of a dime. So if they're eating this stuff and they're not chewing super well, or it's kind of getting clumped together, that can cause an obstruction or something. So no coconut for bypasses. Coconut flavored stuff is fine, but just not the fruit itself. Really at maximum, they're only gonna eat about a cup total of food at a time. So if you imagine taking your whole meal and putting it into a 1 cup measuring cup, that's about all they get. But after the sleeve, their stomach is about the size of a banana, so you can't put much in there. And then after a bypass, it's about the size of an egg-ish, so very small space. So bypass patients usually never see that 1 cup amount unless they're like trying really hard and making themselves really sick. So that's kind of the overview of the diet. Most of the time if patients are having pain, regurgitation, indigestion after they're eating too much, too fast, or the wrong texture. Maybe they just don't tolerate that texture yet and they need to back off a little bit. So nausea and stuff, once they're recovered, should not really be their new normal. If they're having nausea all the time or diarrhea all the time, we need to look at their food choices for sure. So that's kind of the overview on the diet stuff. That other booklet that you have, the spiral bound one, is like the bariatric Bible that we give them basically before surgery. So you have that as well. That's what all the patients get when they're new to us, just so you can see what they are getting. So you have that as a reference too. Alrighty, questions? No? Okay. Good deal. Whitney, did I miss anything? Is there anything you wanna explain or talk to them about since you kind of did it hands-on?
I don't think you missed anything. The only thing I would say is that Tanya, when she was here last week, she kind of asked what was different about like a regular surgery patient. And honestly, I think that you guys are the best floor because you're so used to having surgical patients that I don't know that it's going to be such a big transition for you. It's just learning the order sets, and like now you guys have a couple orthos who do different conflicting things. You won't have that problem because there's just the one surgeon. So if you follow that order set and that checklist, it's pretty easy.
we, like I said, that first patient is it next week, I guess, the 13th? Yeah, I guess that is next week, isn't it?